Good morning. I'm Dr. Deuk. It's November 21st, 2023. We're going to be broadcasting surgery live. Our patient has had 12 years of back pain. It's coming from the discs at L3-4, L4-5, L5-S1. He has herniated discs, degenerated discs, bulging discs. He also has facet joint pain at L5-S1 on the right side. We're going to be treating the right L5-S1 facet with our Deuk plasma rhizotomy. But first, we have a bilateral Deuk laser disc repair. We're going to be fixing herniated, degenerated discs with the laser. And specifically, our goal is to eliminate pain and get his nerve roots decompressed. So we've got two goals with the surgery: get rid of the back pain he's had and unpinch the nerves so that he can start getting strength back in his legs. He's had a difficulty with walking, difficulty with standing. His posture is really bad because he's had back pain and pinched nerves for so long. Now, he's a good example of a patient who is going to take time for the healing to occur after surgery. And what has to heal are joints and muscles. Joints and muscles. Okay? Surgery can never heal joints and muscles. Shot. And nerves. Surgery itself will not heal nerves. Okay, we're on the left side. We're going L3-4, L4-5, correct? So we'll start with L4-5, and then we'll go to L3-4. Num. If you have questions during surgery, feel free to ask. We take questions on any subject related to spine surgery. Whether it's surgery, physical therapy, medications, even anesthesia. If you have a question, we'll do our very best to answer it for you. All right, first disc I'm going to go after is the L4-5. Shot. I may want to start a little bit higher. Shot. For this surgery, patients are awake. Shot. And he has an interesting spine. I can already tell his spine is not terribly deep. It's about the average depth, like deep inside the body. All right, we're going to have to back up a little bit and shot. AP. The first step of the surgery is to access all the herniated discs using a needle. I see. So he does have some scoliosis. All right. Shot. So we're a little bit below the disc, and his facet joints are pushing me. Shot. Let's get an AP. Any questions from the audience?
No questions.
All right, so we're pretty far lateral. It's a transverse process, that's why. All right, let's go back to a lateral view. His spine is actually quite posterior. That feels like facet. Shot. Got a lot of arthritis of his facet joints. You can feel it. Shot. Let's get an AP. So we're going to go back and forth between AP and lateral. This light is right in my face.
Turn it off too.
What? You guys, we need to do the same thing every time. There shouldn't be any variation. Shot. You can see all the bone spurs coming off of the spine there. Shot. Shot. How's he doing? Shot.
How are you feeling, my friend? You okay? You pain in your nose? Okay, I can fix it. That's just a mask.
Shot.
Thanks for telling me. Better?
Shot.
Better?
So we're really close to where we need to be. I'm trying to get into the disc.
Are you having any discomfort in your legs? Okay, good.
You're doing great.
No discomfort.
Right there. You can see the needle is starting to move in the right direction. Very tight. You're doing great. Just hang in there. Thanks. You're doing excellent. Everything's going well for you. So the patient has to be awake because they're helping me. I need to know if I'm too close to the nerve roots, and the only way to know is for the patient. The only way to know for sure is for the patient to tell me. All right, Jordan. So we're going to go for the disc above. Now I can use the X-ray, but the X-ray doesn't show nerve roots. It shows where the nerve roots are supposed to be. Shot. Unfortunately, with all the arthritis these patients have in their spine, the nerve roots get moved around by the arthritis. Shot. So they're not always exactly where they're supposed to be. Shot. Therefore, it makes my job a little bit more difficult. Shot. Because I have to, shot, navigate around these arthritic parts of the spine. And I'm very close to where the nerve roots are supposed to be. Shot. So in reality, I need the patient's help to make sure we're not too close. Shot. Give me an AP. All right, we're sneaking up on the L3-4 disc on the left side. You can see the end plates are sclerotic. Yeah. So, too lateral. His scoliosis is really moving that spine over. Shot. Shot. Any questions?
No questions.
Why don't you show the video on what causes? I think I'm hitting the TP again. Let's go back to an AP. What causes back pain with a herniated disc? Because of the curvature of his spine, I have to make a separate incision for the next disc above. Typically, we could get both of them at the same time. Shot? But I'm not able to do that. Shot? That said, everything is going well. He's comfortable at this time. Shot? It's just he has some unusual orientation of the discs in terms of the angle of the disc, so my entry to the disc are in different trajectories, meaning I have to have different starting points. Shot? There we go. All right. We're going on this side? Correct?
We can, or are you gonna use the same one over here or not? A different one? No, it's only two on the side?
That's correct.
Okay, so yeah.
We have a question from Jamie on YouTube.
So we're bilateral. Before we take the question, let me just verify. Bilateral 3-4-4-5 and a right 5-1. Okay, we're good. Thank you, Luis. Yeah. Yes, Jamie.
So, how does the patient react when too close to the nerve?
Yeah, great question, Jamie. When we're too close to the nerve, the patient will say, I have leg pain down my leg. That's why we have to have the patient awake. We won't know if the patient has leg pain unless they're awake. Shot? Give me an AP. So awake surgeries are done all the time these days. You've probably seen awake brain surgery. If you haven't, you should watch it. It's quite interesting. With awake brain surgery, it's the same thing. It's all about functional mapping. The surgeon wants to know where the delicate areas of the brain are. We want to know where the delicate areas of the nerves are in this area. So it's the same principle. Avoid injuring delicate neural structures. Whether you're doing awake brain surgery or you're doing awake spine surgery, you need the patient's participation so you can assess your surgical plan and trajectory to make sure you're not doing any damage to vital structures. We're not the first to do awake spine surgery. This was something that was taught to me by my predecessors. They did the same. We all used, shot? Man, that seemed like a big tear. AP? We all used awake spine surgery. It's common for endoscopic transforaminal surgery. Wow, we're in. All right, that's good. There's a huge tear on the right side. He seems to have more symptoms on his right. I'm going to try to make it, let's see. I mean, I should be able to make it into 3-4. I'm not going to do 5-1 yet because from my standpoint, 5-1 is probably going to be the hardest to get to. So I may have to take a separate entrance. By the way, if you're wondering and you've watched us do these surgeries before, why are we making, 2 incisions on the side rather than 1? The answer is because of his spine, the way it's curved. Everybody's spine is different, but most people we can get 1 incision on each side and do the job through the 1 incision. Unfortunately, some patients have their disc, if you look at the plane of the disc, and imagine the plane of the disc projecting, I need less pressure, out to the skin, you'll realize that the trajectories are not optimal to come to the same point, AP, in every patient, okay? And scoliosis makes it harder for the disc planes to line up on the skin at the same target, which is normally what we like to see. We like to see, yes, we like to see the entry point be the same for all the discs. And when you don't have too much scoliosis, that's possible to do that. It's possible. Unfortunately, it's not always possible, and the more scoliotic a patient's spine is, the less likely you can have all the entry points be the same. All right, so you can see things are looking pretty good there. We're trying to get around the facet, Sean. Very arthritic facets, by the way. Full of arthritis. I can feel the arthritis as I'm passing them. Sean? Yeah. On a level of 1 to 10, this is definitely a 10 case. Probably from, I imagine, an anesthesia standpoint, it's a 10 as well, right? 9? So generous. Well, there you have it. So from my standpoint, this is a 10. From an anesthesia standpoint, it's a 9. Still a pretty difficult case. Shot? Uh-huh. All right, now we're heading for L5-S1. And just look at how the needles just don't even like match up with each other. That's because of the scoliosis. Is that the best 5-1 you can give me? Yeah, it probably is. 5-1 is in such bad shape. It's very collapsed. All right, so if you haven't done this already, Sanjay, would you please run the educational video showing our audience how is it that the Deuk laser disc repair does its work? How does it work to fix back pain? Disc. All right, welcome back. You can see how the Deuk laser disc repair procedure actually works to eliminate pain from the disc. The key is, hold on, we're not done yet. The key is we need to get into the disc and find the tear in the back wall called the posterior annular tear. And Deuk Spine Institute, we're the ones who I discovered that the posterior annular tear is the cause of people's discogenic back pain. And of course, now we go in and we can repair the tear with the laser. And what that does is it gets rid of the patient's back pain. Where do you feel that?
Where are you feeling that?
In your back?
In your back or your ribs?
You don't feel anything. Yeah. Wonderful. Boy, that 5-1 is going to be tough. It's so collapsed. AP? I feel like I'm right on the back of the disc at this point at 5-1. We've already accessed the other ones. We're going to be testing his disc shortly. So this is a study we just literally submitted for publication. that 5-1 I'm not happy with. I wonder if we can do a better job. Jordan, I mean, I think we're off on orbit a little. Let's play with the orbit just a minute, get a few degrees. While Jordan is playing with the orbit, the WAG looks perfect on that. But I think the orbit's good right there. What do you think? Yeah, it's fine. Huh. I just can't get this needle any further in. It's literally hitting bone spurs. I just can't get it in. I'm going to have to try a different trajectory. I think. I'd hate to lose it. You know what? Do we have another one of these? Huh? Yeah, I know. I'm just trying to figure out if I can get into 5-1. Do you have any more num-num skin? You're doing great. We're almost done. We're going to put you to sleep in just a minute, okay? I'm just giving you some more numbing medicine. I'm trying to get into your last disc.
On the last one, and then we're done. It wasn't too bad, was it?
And I'll tell you guys in a moment. I'll tell you about the study we just did for chronic lower back pain. Shot? It turns out that 85% of chronic lower back pain, shot, comes from the disc. 85%. From a disc injury, like a herniated disc, degenerated disc.
In your back?
Shot?
You still have a little bit in his back.
Yeah.
You having that in your back?
Shot?
Say it again? You have to pee.
Oh, great. Well, you can go. Yeah. All right. Okay. Are you comfy? How long have you, besides that, how long have you had back pain for?
You said longer than 12 years? More than 12 years.
All right. Are you having any pain right now in your back? No? How bad is that on a scale of 1 to 10?
Give us a number.
10 being the worst pain.
9.
9, is that where you get your back pain? All right. How bad is that on a scale of 1 to 10? 10? Is that where you get your back pain typically?
Said yes.
All right. We're going to put you to sleep. When you wake up, we'll be done. No. All right. Count from 1 to 100. Pressure here. Okay. Pressure here. Leave that alone, please. Okay, well, we know that the two discs, L3-445, are definitely causing his pain. He's got a long surgery ahead of him, got about an hour or so. It's going to be all right. Count from 1 to 100, good. Nice and loud. Any questions for us, Sean?
We have a question from
Sean?
Deuk on YouTube.
Uh-huh. Teak, hi, welcome.
Peel on needle. When you go through arthritis,
Yeah.
is it a gritty sensation or
Yes.
like a poking hard tissues?
It's both. You feel hard tissues and you feel a knife and you feel gritty. You feel both. You feel irregularity with the needle tip. You can actually feel it. And it feels gritty, irregular. There's areas of increased resistance and decreased resistance, you know, depending on bone spur or what do you call it, scar tissue around the arthritis joint. But basically, It doesn't feel like muscles, which normally you're splitting the muscles, right? You're just separating the fibers. But when you get to shot, this fluoro is too close right here. When you get to arthritis, real bad arthritis with bone spurs, you can literally feel the arthritis. Hold on. All right. All right, very good. Now, as we do this, you're going to see the needle from the other side, inside the disc, most likely. Very common to see that. Keep the questions coming. We'll do our best to answer them. So what are we treating here? People think they need to have their scoliosis corrected. They need screws, rods, osteotomies, but you don't. I used to do that surgery all the time. We would do scoliosis surgery every week. And I would cut out all the arthritic joints and put cages and correct the alignment of the spine. And it turns out that none of it's necessary, because what people want to get rid of is their back pain. And the reality is you can get rid of the back pain without doing scoliosis corrective surgery. Okay? You just need to find the source. And it turns out we're inside the disc, by the way. Look at the pink tissue. You see the pink tissue? That's the source of the back pain right there. If you get rid of this pink stuff and get rid of the source of inflammation, the pink stuff, which is the herniated disc within the annular tear, you get rid of back pain. So what I was going to tell you is we just completed a study of 200 patients with chronic back pain that came to Deuk Spine with back pain. It turns out 86% of them, their primary cause of back pain is a disc injury. Now, you may not be familiar with the term disc injury, and what disc injury means is many things. It could be a herniated disc. It is herniated disc. It is bulging disc. It is degenerated disc, like this one here you can see is very degenerated. But there are many names for disc injuries, but they're all disc injuries, okay? And what I'm saying to you is it doesn't matter what the name is, the pain source is the same, okay? It's like me saying it doesn't matter if you're American or Chinese or Mexican or Italian. We all have a heart that beats and pumps our blood around, right? So we have that in common. That's a common feature. And I'm telling you right now, the most common feature of people with chronic back pain, it is a disc injury, whatever you want to call it. It doesn't matter. The name is not important. What's important is that you realize the pain comes from the disc. And that's important because so many people nowadays have chronic pain. They don't know where it's coming from. Their doctors have no clue where it's coming from whatsoever. So this is the first of its kind paper. It's never been published before. The actual breakdown of what the causes of back pain are in chronic back pain. Okay? So we took 200 patients with chronic back pain, and we broke down them into categories of what's causing their pain. You have any Scotch tape?
I can put
I'm just kidding.
Yeah,
And
I'm sure I can do it.
I'm joking. I don't want tape. I'm joking. And so the disc was 86% of the time the major cause. The facet joints were the second most common major cause at basically 9%. 9%. Let's just call it 10% for ease. So 85% of chronic back pain is discogenic, 10% is facetogenic. And that's 95% of chronic back pain between the disc and the facet. And then there's the SI joints, which are, I think, like, if I remember correctly, 1% or 1.5%, something like that. Piriformis muscle, which is another, 1%. And then fractures, vertebral body fractures, we hear about all the time. So these are, of course, patients in private practice.
Seems like it lines up with our practice here.
Huh?
Seems like it lines up with your practice here.
No, this was my publication.
Oh, okay.
This is our data. This is our data. Yeah, these are our patients. No, this is the paper I just submitted for publication. So this is our patients. So it turns out that, of course, you have to understand something, though. Remember, these patients are ones that don't have infections of the spine or tumors, because the patients with infections and tumors, they don't come to us. As soon as their doctor sees an infection or a tumor, they'll send those patients to a cancer treatment center, for example, Moffitt, right? So the data is, of course, not my selection, but it's naturally selected by doctors and the community and, whatever the karma of the universe. The point is that we don't get patients with tumors sent here. We get patients with non-tumors and infections and fractures seen on their imaging, okay? Yeah, it's a natural demographic. So the point is that it's a common demographic, though, for people living with chronic back pain. The most common secondary cause of pain found in 45% of all the patients was facet joint pain. Facet joint pain. Okay, so it was found in 35% of patients whose primary pain was the disc. Their major source of pain was the disc. But in 35%, so a third of those patients also have facet pain. It's very important, okay, to understand these numbers and the impact. It's going to change healthcare and medicine. When doctors start to understand what's causing back pain and they're able to fix it, people are going to get out of pain. Now, I try teaching people online all the time, our website, our Facebook, our YouTube videos, but my message is not getting out enough. So, I'm using the peer review publication process to spread the word, and hopefully some people, doctors, will start listening, maybe nurses, and start, practicing properly to get people who have chronic pain the proper treatment they need, which is going to be obviously the Deuk laser disc repair for the disc problems, and then the Deuk plasma rhizotomy for the facet and SI joint problems. The second most common secondary cause of pain after the facet joints was surprisingly the piriformis muscle. I want to say 30% of the patients, if I remember correctly, had piriformis muscle pain. Severe,
Is that related to altered spine biomechanics?
Yes, it's exactly altered spinal biomechanics. So, pain in the buttock, very common. Their gait is shifted, their nerves are being pinched, for example, radiculopathy, it causes them to walk funny, and then they overstretch that muscle in their buttock, and that causes pain. Yeah, that's right. Dr. Berndes is just noting that, he sees these patients, so he likes to make the correlation. Yeah, anyway, I submitted the data to the Southern Neurosurgery Society meeting, and that's going to be next year in March in Orlando. Anybody want to come to it? It's going to be in Orlando, Florida, near Deuk Spine. It's close by. And I requested being a speaker to be able to share this information with doctors. Last year the SNS was, yeah, you're right. It was on the west coast of Florida. Yeah, Arias and I went. We actually had some posters. We had some publications as well. So, all right, questions from our audience.
We have a question from Eric on YouTube.
Yeah. All right, I'll take it.
Just signed on. Those disk spaces look pretty desiccated.
Yeah.
Why do DLDR instead of fusion?
Why do fusion? Derek, why do a fusion? It's unnecessary. Fusion is dangerous, bloody, scar tissue. Patients who have fusions have to take painkillers for months afterwards. Narcotic opioid painkillers, dangerous drugs. People die from those drugs. With the Deuk laser disc repair, there's no bleeding, there's no scar tissue, there's no hospital, there's no narcotics, there's no post-operative pain like you have with a fusion. Plus, why would you want metal in your spine? The only reason to do fusion is if you want to make more money as a surgeon or hospital. There's no benefit to the patient to do fusion. We can get rid of more pain in the back and legs with this surgery than you can with a fusion. Fusion has all kinds of problems. Adjacent segment disease, hardware failure, hardware loosening, broken hardware, misplaced hardware, failed fusion, cage migration, infection, blood clots in the legs, blood clots in the lungs, heart attack, pneumonia, chest pain, cardiac ischemia, muscle atrophy, muscle death. This is clogged, I think.
Let me check.
Lots of bad things happen with fusion. They don't happen with this surgery. These people go home in an hour after their surgery. Where's the roll? If I did this surgery as a fusion, this patient would lose probably 250 cc's of blood. We're going to lose about 2.5 cc's of blood. I want a rolled blue towel, like I always do. Okay? That's what I'm supposed to have. There's a reason for it. It's not optional. It's a tight roll. Take this. Yeah. Why would anybody... That's like saying, okay, Japan, let's talk about this war. You're going to stop. And Japan says, okay, we'll stop. And then you say, let's drop a nuclear bomb anyway. Why would you want to destroy people's lives and buildings and create radiation and nuclear fallout when you could do it politically? You know, when you could just go have a talk with somebody. It's why use a sledgehammer when you can use some glue? I mean, it makes no sense. Why go to war when you can solve problems politically? This is a political solution to back pain. This is a non-traumatic, safe, better effective than having war, you know, and destroying. Fusion is a destructive surgery. It's totally unnecessary. The problem is that the people that do fusion, the hospitals, the insurance, the surgeons, the companies that make the implants, they're all getting filthy rich off those surgeries. Meanwhile, the patients are suffering from the complications and aftermath of those surgeries. There's absolutely no reason to do a fusion. That comes from a surgeon who's done 1,000 fusions on the lower back. I've done all of both, 1,000 lasers, 1,000 fusions. There's nobody else on earth that has done as many fusions and endoscopic laser surgery as I have. I've done more than any human being alive because I was brought up in the fusion era. You show me any surgeon in the world who's done 1,000 lumbar fusions. I've even published on lumbar fusions on PubMed. Go look my name up. You'll see lumbar fusion, Dr. Ara Deuk-Majan. I've published on it. That means I'm a world leader, an expert on fusion, okay? I've done 1,000. So show me one surgeon in the world who's done 1,000 lumbar fusions and 1,000 lumbar Deuk laser disc repairs or endoscopic surgery. You will not find that person but me. I'm the only one, the most qualified of all. And I'm telling you, fusion is completely unnecessary to treat back pain. There is no advantage of fusion over this surgery. Not a single advantage. Only disadvantages, including pain and suffering. Why would anybody want metal in their back? The metal I'm putting in is temporary. Okay, just about in. There we go. Looking good. Just take that out.
What percentage of fusions are guaranteed to get adjacent segment disease in the lumbar region?
There's so many problems with fusions that there's no comparison. People are brainwashed. That's the problem. It reminds me of Nazi Germany, when the Germans were brainwashed that Jewish people are inferior or bad. It's the same. There's no difference. They've been brainwashed to believe that fusion is better than anything else, that metal is better. And their treatments are destroying lives. People's lives are being destroyed by aggressive procedures. Their lives are completely destroyed. Okay, you have to live in pain and suffering, because the fusion doesn't fix your pain and suffering. You're going to have more. Then they send them to pain management. Of course, the pain management doesn't fix their pain and suffering. So the fusion didn't, the pain management doesn't. And then they get more fusion, adjacent segment disease, and they have the complications of fusion, all the scar tissue, the bleeding, the pain meds, the narcotics, if they survive, and they don't get addicted, right?
And a lot
I
of
mean,
times they leave the disc in place in the same location as it was, right? The fusion, you mentioned that.
there's absolutely zero reason to have fusion compared to this surgery. Zero. There's nothing better. Which it has a faster recovery. This is a 1 hour recovery. Fusion is 3 to 5 days, sometimes a week, right? I mean, sometimes people never recover. Which one has no narcotics used after surgery? No new narcotics being given. Fusion, you have to have narcotic painkillers. You're going to be on Percocets, oxycodones, whatever the doctor gives you, Dilaudid, hydromorphone. This surgery, no narcotics. I mean, the list goes on and on and on. So that's why we do these broadcasts, is to educate people. You can see a small incision, you can see it's outpatient. There's absolutely no reason to do fusion or any invasive surgeries. This surgery replaces all of those. Any other questions, Sanjay?
We have a question from And Justice for All.
Mm-hmm, sure.
Hi,
there.
Dr. Duke.
Hello.
I have been watching spicy surgeries over the internet recently,
Uh-huh.
and almost nobody is doing discograms during surgery. What is your opinion on that?
I think they're doing a disservice to patients. Why would to do a discogram, why did you guys switch the feed? Who switched that?
No. That's
Oh, okay, sorry.
check that one.
I see. Yeah, the discogram would require the patient to be awake if they're going to elicit a response. So most surgeons can't do awake surgery. They don't know how. It's a skill, a talent to be able to do awake surgery. It's much harder than putting the patient to sleep. But it gives you information about the disc, whether it's painful or not, which other surgeons are not getting. And that's why other surgeons have such high failure rates. The patients who had the Deuk laser disc repair have 99.5% of their disc pain is eliminated with this surgery. There's no surgery, no fusion, no other surgery in the world where the surgeon can get rid of 99.5% of the pain. Those other surgeries you're watching, the surgeons might get rid of 25% of the pain, 50%. There's the needle from the other side. You guys see it? Right there?
Yes, we
That
do.
metal?
Yes, we do.
All right. No, I'm just laughing at some of the questions. Any other questions, Sanjay?
We have a comment from FC on YouTube.
All right, FC.
Hi, Dr. Duke.
Hi.
I submitted my MRI almost a month ago for review,
Uh-huh.
but have not heard anything. Just checking as I need a second opinion.
Yeah.
Current treatment is not working. Thanks.
Hey, FC. So, first of all, if you just send us your MRI, you won't get anything. The MRI review is a virtual visit. I meet with you on Zoom. But for you to get the MRI review, you have to send us your MRI films, and you have to fill out the form. Once we receive the form and the films and the report, all three, that's when you're going to get an email saying we're ready to schedule you. So the only reason I can think that you haven't gotten your anything back is you haven't sent us everything. So did you fill the form out completely? Did you send us the MRI images? Did you send us the MRI report? Three things we have to have. And you won't get your Zoom meeting with me until you've done that. If you have done all three, then post your information right here. Sanjay will figure out, give it to me, and I'll do an investigation and find out, you know, why we haven't reached out to you. But it's never really our team's fault. It's always the patients or the people like you that haven't done things right. You haven't filled out the form and submitted it. You haven't sent us your MRI images, their DICOM images, or you haven't sent us your MRI report. So you have to do all three to get your telemedicine Zoom meeting with me. Yeah, you can imagine we get a lot of requests for help. I'm happy to help everybody. Our visits are free on Zoom. You get one free visit, and you're basically getting $1,000 worth of free service. But to get that $1,000 free service from me, you have to provide us with everything we need. So follow the instructions. If there's something you haven't done, I suggest you go back and do it. On the other hand, if you've done it all, then I would love to know what's going on. So give me your information. Give it to Sanjay. If you type it in, he'll give it to me, and I can investigate and find out why. But typically, once we have your form filled out on the website, your MRI images on our have been sent to us, and they're loaded on our PAC system, and we have your MRI report, then we can get you scheduled within a week for Zoom. 1 week. That's all it takes. So I would recommend evaluating what you've done and what you haven't done. Sanjay, if you have more questions, this would be the time you can ask them. Sanjay?
Copy that?
All right. All right, we've shown both of our videos, right?
Yes.
You know, we used to show a comparison video of the Deuk laser disc repair with the fusion. You've seen that one, right? The lumbar fusion?
Yes.
But I'm pretty sure that if we do that, we're guaranteeing that this video will be age restricted, right?
I guess so.
Yeah, that's what happens. So if we show a comparison video with all that meat and potatoes from a fusion surgery, the YouTube is going to age restrict this whole live stream, which I don't I don't think we're currently age restricted on the live streams, are we?
I don't think so, doctor.
Yeah, I think
Yep,
that's
yep,
why we
yep.
used to show that video. Because it's really good to see a comparison of the fusion, what happens during the fusion versus the Deuk laser disc repair. It's very informative. But you know what you can do? Why don't you put a link to that video in the dialog box? You know which video I'm talking about?
Yes, it's the lumbar comparison.
Lumbar comparison. We have a ACDF versus DLDR, and we have a lumbar fusion TLIF versus DLDR. You can put that link, and I don't think that will create a problem. Why don't you do that for whoever asked about why not do a fusion?
Versus DLDR. Yes.
Thank you. All right, just about done here with this one. This is the L3-4, right, Luis? And we've gotten rid of the herniation. Scope off. I need the dilator. Any questions? So we're done with 2 of these discs. We've got a couple more to go. And then we're going to do our DPR, and then we'll be done. This is our very long case for the day.
We have a question from Josh on YouTube.
Yes, Josh.
Dr. Deuk, is it good for your company to get a referral from another surgeon to help with my claim? I sent one yesterday to Kim from surgeon in my hometown.
I don't think it matters if another surgeon refers you, but that's great. I mean, it can't hurt, right? So I'm not sure where your surgeon is or what your situation is, but first of all, I don't need another surgeon's opinion for me to know what's right and wrong to take care of a patient. But if you're asking, will the other surgeon's referral help with getting your insurance to pay for the surgery, I think it would be helpful, yes. And we will use it, for sure. Where are you going? Let me see.
Can you?
Yeah. Shot? So, Shot? Have these come out at all? Shot? No, right? Shot? 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 All right, sorry, give me a minute. Shot? Uh-huh. Shot? 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 You see the guide wire there, Jordan? Shot? Not yet. Shot? Shot? Still in the needle, right? Shot? That's what I figured. There it is. Shot? Yeah. It's incredible, huh? How some of these discs will actually bend the needle so much. It makes... Can you hold this side here?
Yes, sir.
It makes getting the guide wire in very difficult. Shot? Shot? All right, so the guide wire is there. It's embedded. Jeez, shot? Just the needle is grabbing onto it. Shot? All right. Shot? Uh-huh. Shot? All right, good. All right, was there another question? None?
No questions.
Okay. Shot? as you advance your dilator, you want to make sure the guide wire doesn't advance with it. Shot? Sometimes if there's a kink between the dilator tip and the guide wire, you can get the guide wire doing things it's not supposed to do. Take. You could see from the way we do things that the placement of the needle is the most important step in the surgery. Of course, you can create problems along the way, you know, during the dilator placement, tube placement. But really, once you get the needle in position, and you know the path from the skin to the disc is safe, then the rest of it's pretty easy to do. Shot? Shot? All right. You can see the dilator is sliding along the guide wire, which the guide wire guides the dilator. That's the whole point. Take. Uh-huh. All right, we're now entering the disc. That looks good. We're going to place the tube that we're going to do the entire surgery. It's called the endoscopic tube, or cannula is another name for it. So this patient, I'll tell you, is incredibly deconditioned. I'm going to talk a little bit about deconditioning because it's important. Some patients think that when they're done with surgery that their bodies are magically going to recondition. They don't. Deconditioning refers to changes in muscles, changes in joints, changes in nerves, soft tissues that occur over time. And they're due to abnormalities of walking, standing, posture, gait, we call it, that occur because patients have pain or neurological compromise from nerves being pinched and damaged, so that they basically don't have a normal gait, normal posture, normal activities. And those abnormal movements and postures cause muscles to atrophy and shrivel up, and it causes soft tissues to basically get thin and weak. Contractures can occur, and we call it all deconditioning. Okay, nerves can actually get crushed and damaged and scarred. You get chronic radiculopathy. The point is, this surgery won't fix things that have gone on for years. Now, what will fix it is the patients after surgery. They have to go and do basically rehabilitation. Okay. Now, most of our patients that we treat, fortunately, they're not horribly debilitated to where they can't, function. But once in a while, we get somebody who is. And this patient is one of those patients that are extremely deconditioned. And so fixing the discs, unpinching the nerves is not going to recondition their body. They have to do that after surgery. What we're doing is we're getting rid of the pain in their back from the disc. We're unpinching the nerve so that the disc can heal, the nerves can heal, but more importantly, the patient can get out and start doing things physically that are going to help recondition the muscles, the ligaments, the tendons, the soft tissues, and get them back in shape to where they're not weak and decrepit, basically. So some people, they do wait. They don't know about us. It's not their fault. This patient, for example, has had horrible pain in his back for 15 years. I think it's been a lot longer than that, but I think it's gotten really bad in the last 15 years. So think about 15 years of horrible pain where you can't really run and jog and exercise like people go to the gym and exercise, right? So they're very limited on their activities. And as a result, the muscles shrivel up, the ligaments and tendons get weak and are easily injured. And this surgery is not fixing ligaments and tendons and muscles. The surgery here is fixing pinched nerves as well as the disc pain. Okay? So nerve compression and disc pain, back pain. Now back pain exacts a tremendous toll on people's lives. It keeps people from doing normal activities. It keeps them from standing normally, walking normally, normal exercise and activities. So once you get rid of the back pain from the disc, patients still have the pain in their muscles, tendons that we're not fixing that has to recover over time. And typically the symptom patients will have is they'll notice that they get tired quickly. That's because they're not used to using those muscles. So I try to explain that to my patients ahead of time before surgery. It's going to take you a long time to recover from surgery. Now some patients come in and they're easy to see, like they're in a wheelchair, their muscles are so atrophied, their legs are skinny, their muscles are skinny, more on one side than the other. That atrophy of the muscles is going to take years to fix. It's going to take years of them doing physical therapy, getting stretched, building up the muscles and tone. It's not impossible. It's just not easy. The surgery is easy. Rehabilitation is not easy.
Thank you.
These are all pieces of herniation inside the disc coming out. Most of them are scarred pretty bad. That's why you see the thick white stuff. That's scar tissue. Any questions?
We have a question from Yin Yang Yu on YouTube.
Sure.
Doctor, I have a bony growth osteophyte on the vertebrae, putting pressure on the nerve and causing numbness and pins. Disc is fine. Can you fix this, or do I need a foraminotomy?
You need to do our MRI review. I don't believe a word you say, because you have honestly no clue what you're talking about. I don't believe a word you say. I will not give advice based on someone else's opinion, especially someone extremely unqualified, like a patient. Okay? That's a mistake people, they think they can just call me and say, hey, what do you think about a bone spur? Well, first of all, I've never seen a bone spur do that. So you would be the first one. So it makes no sense to me. Why would you be the first person with a bone spur that's just a bone spur and nothing wrong with the rest of the disc? So that doesn't add up. So I would recommend, if you want to know what I would do, then you need to submit your MRI. There's no shortcuts, folks. Shortcuts lead to bad treatments, bad outcomes. I don't give patients bad treatments and bad outcomes. I give them very good outcomes. I'm not in the business of giving bad advice. You want my advice, you do it the right way. You give me your MRI images, your MRI report, your history, and then you set up a Zoom call. And I will take my time to guide you and tell you what's wrong and how to fix it. So I won't answer your question because I don't trust the information you're giving me. Some people come here for, I don't know why, they have some weird ulterior motives. I'm not interested in those people. The good news is, folks, these broadcasts you're watching are my broadcasts. I fund them personally. out of my pocket. Because of that, I get to control the content. I get to control everything about them. And the point is, I'm not beholden to anybody. There's no hospital system you can call. If you want to call my boss and complain because you don't like me, you call God. There's nobody above me except God. That's it. So I love it when I piss people off. They're like, who do I need to call and complain? Call your mom. Complain to your mother. That's who you should be calling, because she didn't bring you up properly. Okay? I'm giving you a very clear set of instructions. Fill out the MRI review form. Send us your MRI images. Send us the report. Then ask my opinion about your problem. Only then can I actually give you a qualified opinion. Otherwise, it's just conversation. And I don't do just conversation with anybody. I'm too busy for that. Okay, we're almost done with this disc. We've got another disc to do with the laser. You can see way down inside, there's a little bit of blood clot right there. Guess what that's from? Anybody know? Sanjay.
The blood clot?
Huh?
I'm not sure.
Did we do the same disc on the other side already?
Yes.
That's right. So that blood clot is from when I did the opposite side. There's a little bit of bleeding. You can see that. Not much, just a tiny bit. Nothing to be worried about. Now that there is fat at 12 o'clock. And it's not that I have anything against fat, because I don't. It's just that it's getting in the way of me doing the job. So I had to remove it. All right, any other questions about the spine?
No questions.
All right.
But we have a questions on the insurance claim.
On the what?
Insurance claim
Insurance claim, sure.
from Josh on YouTube.
Uh-huh.
Doc, when does your team start the insurance claim process once you have all the info you have asked for?
Josh, great question. So, Josh, there's different kinds of insurance. So we're talking about types of insurance we'll file claims for and times we won't. The kind of insurance we don't file claims for is Medicare, because Medicare does not pay for new treatments like endoscopic laser surgery. So we're not going to file a claim for Medicare. On the other hand, insurances that are commercial insurances where we can file a claim, we will start that process after you've done your MRI review. Once we know what's wrong and we know what needs to be done to fix it, we're going to make a recommendation. We're going to dictate a letter of medical necessity. We're going to send that letter of medical necessity to your insurance company, asking them to approve your surgery. Now, whether or not they approve your surgery doesn't change the fact that everybody has to pay some money up front, unless we have a contract with your insurance company where they're going to pay the full amount before surgery within 45 days. Under those circumstances, then we don't have to charge any money up front as long as we have a contract. It has to be a valid contract, one that's enforceable. So we start the insurance process once we've done your MRI review and we know what needs to be done. Hopefully that answers your question. Remember, a note on insurance. If your insurance doesn't pay for your surgery, whether it's a Deuk spine or somewhere else, that's something between the patient and their insurance. You guys, that's your issue. You got to deal with it with your insurance company. The good news is we will help you by providing you support, documents, expertise. My billing staff have, for example, all the FDA approval letters for the Deuk laser disc repair equipment we're going to submit that to the insurance. Sometimes insurances are confused. They think this is not an FDA approved procedure, but it is. So we provide all that documentation, not to the patient, but to the insurance company. All right, just about done here. A few more seconds. So far this looks good though. We've gotten rid of the part of the herniation that was pinching the nerve. I've probably gotten rid of 60% of this herniation. Remember, we're never going to get rid of 100%. By the way, there's the nerve right there. You guys see the nerve? Just outside of the tube?
Yes, we
Right
do.
here. That's the nerve root. And specifically the dorsal root ganglion right there. And that's fat around the nerve. Why? Because nerves, they need a lot of energy to do their job. But you see how close the herniation is. It's all scar tissue here. I'm not here to remove scar tissue. I'm here to remove inflammatory tissue and the herniation. I don't see any more. Josh. All right, any more questions?
No questions.
Huh? One. I'm done. I just need to. Did we lose something?
What is it?
A needle? There's a needle on the floor. Should be okay though. We have plenty more. Yeah, good. Okay. So abort L5-S1 right side. Anatomical restriction. For the DLDR, we're still doing the DPR.
We have a question from Yin Yang Yu on YouTube.
Sure.
Could the remaining herniation ever continue to cause pain?
Could the remaining herniation ever continue to cause pain? That's a great question. I think it's a very good question. You know, you would think that it could, right? But the reality is that every time we do this surgery, 99.5% of the pain is gone. I truly believe it's 100, but 99.5 rounds up to 100. So that's with 100 patients we looked at recently. So we never get 100% of the disc out, ever. We always leave some herniation. It doesn't matter what surgery a spine surgeon does, whether they do a fusion, an artificial disc, a discectomy, a microdiscectomy, whatever you do, the herniation, there's some always left behind, always, 100% of the time. It's impossible for a human being to get all the herniation. So that said, why are we still able to get rid of 100% of the pain? The answer is, obviously, we don't have to get rid of 100% of the herniation. That's all I can tell you. I can't tell you anything more than that because I don't know why. I don't have a good answer. It's just an observation, right, that I've made. And it's true, whether I did a fusion here or I did the Deuk laser disc repair. Everything okay? It doesn't matter what surgery, if I did a fusion or the Deuk laser disc repair, they both result in 100% of the pain going away from the disc. So, why is that? Why doesn't the pain come back? I don't know. I don't have all the answers. It's a very good question, though. I think the reason is that we're getting rid of the main, all the little pieces of herniation. And what we're leaving is just mostly scar tissue. Scar tissue that's there. You know, scar tissue is also considered part of the herniation. No? Huh? Is that, we haven't made any progress getting that out? Let me see. Huh? All right, so we got a little cold welding between the dilator and the tube going on.
Vice grip, please. Vice grip, please. Yeah. Push it more,
Whew. No. Nope. Stuck in there. Stuck in there damn good. I don't want to destroy the, let me see. You on?
Huh?
Are you on there? Let me see, please.
Yeah.
No. Is it on? Because it's not moving. Where's the vice grip? How does Destiny not know where it is? Destiny, you got to know these things. All right, bring the fluoro in. Give me an AP. Come on. Luis, I would recommend you get to the bottom of it.
Yes, sir. No, no.
Hmm? I'm not much for wasting time. Shot? All right. I think we're going to need to see. So I'm at 3-4, correct?
Yes, sir.
So there's 5-1. Okay, we needed to do 5 and S1. I need to be a little bit more lateral. Meanwhile, you guys are working on the vice grip, right, Shot?
Yes, sir.
All right. Num. You need the fluoro to the ceiling, please. It's too close. We're going to move into the facet treatment right now while we're waiting to get our vice grip, because we've basically cold welded the tube and the dilator together, which does happen from time to time. And this patient needs his facet joints treated. Let me have that. Is that ready to go or not? I'll take care of this. You work with her. Shot? All right. Shot? Oh yeah, that looks pretty good, huh? I feel the bone. You guys got to know where this stuff is. Shot? 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 What do you think, Jordan? Looks good, huh? Mm-hmm. Shot? Okay. We're actually doing our Deuk plasma rhizotomy shot right now as we're waiting for more of our instruments to show up. Do we have everything we need, Luis? Shot? All right, looks perfect right there. So this patient has some bad arthritis of the facets, and that arthritis pain is definitely affecting his back pain on the right side at L5-S1. Shot. That's perfect. I think I'd like to do L4-5 while I'm here. Shot. There we go. Shot. Shot. I'm right on the TP there. I can feel it. Doing a little extra for our patient. Just want to make sure he's happy and pain-free. Shot. All right, that's good. Let's get back to our stuck tube. Tools of elegance here. Elegant surgery. Our vice grips. You don't need to grab the. You know, let me just try this first.
But how gonna?
Huh? Let me have the Raytech. Unfortunately, it comes down to sometimes we have to do some interesting things. But this is why we broadcast, so you guys can enjoy this show. I don't think I'm on enough yet. Anyway, in case you didn't know, these are called vice grips. And vice grips are beastly little buggers. They actually destroy our instruments, which is not good. I would use a tip. Maybe even.
Just the line.
What?
Line going vertical. Weighing so much.
It's destroyed. Is it destroyed?
This one is definitely, yeah. We can use it.
Well, we destroyed our dilator. That's $1,000 down the drain. But that's part of doing surgery. Sometimes you end up destroying your equipment. Yeah?
Yes.
What do you got?
I mean, at least it's rotating.
It is rotating?
Yeah.
All right, let me try.
Yeah, but it's just, yeah, it's eating it.
Yeah,
Yeah. Keep going.
it's
Yeah.
we've already lost it, so we need to finish this man's surgery. Yeah, can you guys see this? Sanjay?
Yes, we do.
Just unfortunate. But what's a surgical instrument if it's not to perform a task in surgery? Well, I guess that's gone, huh? Why don't we send it back and tell them it was defective when we got it? Hopefully got a few laughs in and out of the OR. How many those do we have? We have a lot?
We have
Can you
six.
order
I
some more?
4 more.
You need to order more.
I don't know if this is actually getting it. So
Shit.
you want another stop code?
There's nothing I can do. Yeah. So you think it got ruined when we hammered it in?
Probably.
Yeah?
Yeah.
Fuck. It's not our day. Well, at least we finished the DPR, right?
Yes, sir. He's doing well.
Yeah, we're almost done. 5 minutes max. I may lose this tube too, because it's just, he's clamping down so bad on it. Bone spurs. One of the nice things about this technique, it's finally getting cooler in here. The inside out technique is you start inside the disc, you go through the annular tear, herniation, you push the material into the disc, and then these are all pieces of herniation. So I'm actually removing them. They were pushed inside the disc, and now you take them from inside the disc out. We are going to need those vice grips again, probably, to get this tube out. Unfortunately, the tube is ruined as well. There's another $1,500. So these surgeries can be very expensive for us, especially if there's destroyed equipment. We don't charge patients for it directly. It's part of the cost of doing business. Well, we need 5 minutes, Dr. B. I'm almost done. Yeah. All right, any more questions for us?
We have a question from Roscoe on YouTube.
Roscoe.
Why do you think that annular tear surgery to remove loose fragments will ever be covered by insurance?
When do I think it will be covered by insurance?
Why do you think?
When?
Why do you think that annular tear surgery to remove loose fragments will be ever covered by insurance?
Yeah, all right, well, I'll be honest, I'm not entirely sure of the question, but if you're asking when do I think it'll be covered, I wish I had a crystal ball, I could tell you. By the way, it is this surgery here that we're doing, I don't know if that's the same surgery you're referring to. Are you asking about the Deuk laser disc repair surgery? Let's get the... Is Roscoe asking about this surgery?
Doesn't
Or
look like
some
to
other
me.
surgery?
He mentions the surgery to remove the loose
later.
fragments. He says annular tear surgery to remove loose fragments.
I honestly don't know. I couldn't tell you, Roscoe. I don't know what surgery you're referring to. If you're referring to this surgery is covered by insurance. Scope off. We have well over 100 mallet of these surgeries covered by insurance. Are you going to be able to get that out? Hey, scope off. Why is nobody turning the scope off? That's your job. Okay? Don't sit down. Get your work done. Excuse me. We got enough problems on our hands.
He's rotating?
Huh?
He's rotating?
Well, I don't want to destroy the tube. So that's why I put the dilator back in. It's not yet rotating, but I've gotta just get it situated perfectly.
Let's see if now it's dry. Now that he's dilated with the tube.
I don't think so. I tried it with the tube. I tried it with the dilator. Fuck. Let's get the bigger. Son of a gun.
You want to try Botel over there? On the right side?
No, I want to try with the Raytech. Some of you may wonder, why do we have such barbaric tools in the operating room? The answer is we're prepared. You always have to be prepared. Right, Dr. Berndes? Huh? I'm almost there. I'm just trying to take my time and do it right. You know? I don't want to destroy everything here. I'm trying to do it without destroying. I may not be able to. The tube's not turning, right?
No.
Fuck. All right. I guess I'm gonna have to try it without this. So the reason we have these instruments is we have been in this situation before. And having the wrench can be very important in getting out of a jam like this. Well, I'm sure I destroyed our tube. Anyway, you need to stock up. Anyway, yeah.
Before I come in already.
Fucking hell. All right, we're done.
Yeah, I'll see you now, please. Thank you. Can I get a 500 bag of fruits, please?
That's the way the cookie crumbles sometimes. Surgeries aren't as perfect every time. You have to
This is fine.
adapt. Huh?
The scope is fine.
Well, of course the scope is fine. I didn't do anything to the scope. Scope use was a 6. Guys. All right, Sanjay. See the incision here?
Yes, I do.
All right. You can go ahead and go to a testimonial. I'll come and answer questions for people.
I'm here with a patient of mine who traveled all the way from South Carolina to come to the Deuk Spine Institute. She's a healthcare provider herself. She's had some back issues. She had the Deuk laser disc repair yesterday, and she wants to share some of her experience with you. Tell us about your back pain and your leg pain before your surgery yesterday.
I had surgery on L4, L5, L5-S1. So my symptoms were classic. I had the sciatic pain that ran down my leg. Every once in a while my foot would go numb if it was pretty irritated. And then I had pain along the top side of my hip. So pretty normal type stuff. I was going to the chiropractor, I was getting massage therapy, I was starting on meds once I did imaging and made sure that this was actually a herniation and not just like a muscle pull or something. So I had kind of gone through all the things. Had back surgery in 2020 at another institute, and they did a microdiscectomy / laminectomy of L4, L5. I was good for maybe 2 years, almost 2.5. Before it re-herniated. So not the most fun in the world, because you expect whenever you go to have a procedure that it's fixed and your life will be ongoingly better. But I'm a nurse and I ride horses, so I'm pretty mobile all the time, and that kind of pain just really gets you down.
So why did you travel from South Carolina to Deuk Spine? What do we offer here that you couldn't find there?
I was on an internet, the great internet search, to find out more information. So to read more about spine surgeries, about how many times people relapse, like all what's involved. I surely didn't want to go up to a fusion because that's absolutely ridiculous. So I happened to find one of your videos on YouTube. You offered the laser therapy. I was just sold like almost as soon as I saw it. because it made sense to me.
Yeah, having the perspective of being a nurse and a healthcare provider, it makes sense. You're fixing the problem, debriding the disc tear, allowing it to heal naturally into a pain-free state. You had your surgery just yesterday.
Just yesterday.
Not even 24 hours ago. Were you in the hospital for your surgery?
I was here in your surgery site. I got here around 1 o'clock-ish. Did all my pre-op stuff, rolled in probably around 1:35. I think our procedure lasted not quite an hour. I was out and eating dinner with my dad at 5 o'clock at a restaurant that your anesthesiologist recommended.
Oh, good.
Dr. B. He's great.
So no hospitalization.
No.
No morphine pump after surgery because you're in so much pain from
Not
the
at all.
surgery. No narcotic painkillers after surgery, right?
No.
What did you take for pain that we gave you? What new medicine did you take after surgery?
So I haven't taken any new medicine after surgery. I was on Robaxin and gabapentin prior to. Of course, I have to wean off gabapentin, so I did take my gabapentin this morning, but I didn't wake up in any pain. But unfortunately, that med you have to wean off of, so it's not like I can stop it to cold turkey.
Yeah, so basically we did a small incision. We went in with the laser and debrided your tear. And at the end, we had a tiny 7-8 millimeter incision. And there's really no pain after the surgery, so there's no need for narcotics. After your prior microdiscectomy, you probably needed to take some Percocets or oxycodone.
I mean, just to roll out of bed, just to get up off the couch after that surgery.
It's painful.
It's painful.
Yeah.
It's absolutely painful.
And the difference, people ask me, what's the difference between Deuk laser disc repair and a microdiscectomy? The difference is a microdiscectomy goes straight into your spine. The surgeon has to pull all the muscles off your spine. Then they have to drill a hole in the bone to get to the disc. And they have to remove ligaments, and they have to take your facet joint partially out. There's so much destruction that goes on under the skin. The surgeons don't talk to the patients about it because
No, they didn't.
everybody does it. They think there's no better way, but there is a better way. It was developed by an Iranian orthopedic surgeon to come from the side. And I'm a student of one of his students, so second generation endoscopic surgeon, transforaminal. And it's a better surgery because it doesn't cause any damage to your spine or your body. It's wonderful.
It is wonderful, I'd have to say.
And how do you feel today? Is your preoperative pain gone?
Oh yes, all of that's gone. The only thing that I feel is like right in mid-spine where you basically stab me. And that's,
Yeah, you know about
That's-
that. You watched the videos. So,
brought a tear to my eye there for one little second.
I see.
I forgive you.
Thank you. Thank you. Well, I'm glad you're doing well. Is there anything you want to say to your fans and friends out there? Because we know you have friends. I did some shout outs.
Oh yeah, you did do some shout outs to my nurse friends, which I appreciate. And my husband has just been wonderful through all of this. He just wants me pain free and I love him for it. So
That's
he
awesome.
was a major contributor.
What's
even
his
though
name?
Ted, even though he's not here with me,
Hi,
he's
Ted.
here
Thanks
in
for being so
spirit.
supportive. Yeah, you're lucky you have a supportive family. you know.
Absolutely.
It's hard for people to do this alone.
Yeah.
Right?
Yeah, my dad drove me down, so he's been here with me because he can, he's retired, so he can come down. And then my husband, we have a farm, so he stayed to take care of the animals.
Well, congratulations.
Thank you so much. I
Safe
appreciate
travels. You're welcome.
you. Yeah.
All right.
All right, and we have just completed the surgery on this patient who has had 15 years of really bad back pain. He came to us extremely deconditioned, hunched over, barely able to walk, muscles all skinny in his legs. And he was a prime example of somebody who has kind of let their problem go for too long. That said, I can't blame the patient. He probably just didn't have any doctor recommending treatment that works. So he found his way here. It's never too late to get your spine fixed properly, which is what we did today. And the surgery, we had some issues, some challenges. We could not get to the L5-S1 on the right, also because of the arthritis and his anatomy. Also, his discs were so collapsed that they crimped down on my tube, and we were not able to get the tube out without destroying it, unfortunately. So we did have some of our equipment that we had to compromise to get it out. And that happens sometimes. It's not often, thank God, but it does happen. So you got to see some of the challenges of spine surgery. What's the problem?
I was waiting for your son to. That's all.
You got to see some of the challenges of spine surgery, or any surgery for that matter. Surgery doesn't always go exactly as you plan it, no matter how well you do things, how many times you've done it. There's no way you can have a perfect surgery every single time. You're always going to encounter challenges during surgery, whatever they may be. And the truth is that we're pretty familiar with most of the challenges, and we are prepared to deal with the challenges here at Deuk Spine Institute. But, you know, no matter where you have your surgery done, there's always going to be the chance that it doesn't go exactly as planned. So we have to have contingency plans, and we do. Part of our contingency plan, of course, is the use of what you saw today, the vice grips, which we had to use to get the tubes out. All right, any questions, Sanjay?
Yes, we have a question from Yin Yang Yu on YouTube.
Yin Yang Yu, sure.
What is your opinion on fascia and if it has a role in the pain?
Yeah, fascia and the role in pain. Fascia does not have a role in back pain. There's no such thing as fibromyalgia. Fibromyalgia is a made-up diagnosis for doctors that cannot figure out what's causing the patient's pain. And fibromyalgia is, of course, pain in the fascia, soft tissues. I realize I'm not popular saying that, but it is the truth. We have been treating patients with chronic back and neck pain here at Deuk Spine for 20 years. In 20 years, treating only people with back and neck pain, I have seen 0 patients with fibromyalgia. Why is that? We don't exclude them. We will see them. We've never seen somebody with fibromyalgia. For those of you who don't know what fibromyalgia is a diagnosis doctors give to patients when the doctors have no clue what's causing the patient's back pain or neck pain. They just say you have fibromyalgia. I don't know what's going on. If you know, doctors are people. I don't know if you guys realize that, but we have a limit to our knowledge. And so when a doctor gets stumped, rather than saying the right thing, which is, I don't know what's causing your back or neck pain, I'm really not sure, but let me send you to somebody who can figure it out. Let me send you to Deuk Spine Institute. Instead of doing that, that's the right thing to do. What they say is, this is what they're thinking, and this is going to be what you hear. This is what they're thinking. Oh shit, another patient with back pain. Another patient, I have no freaking clue how to make the diagnosis. All right, then what you hear them say is, oh, you have fibromyalgia. The problem with that is that the patients go on to believe they have fibromyalgia, and they start reading about it and they realize there is no cure for fibromyalgia. The problem is they actually have a curable problem. They just need the right diagnosis from somewhere like Deuk Spine Institute. The reason why it's so important is that somebody with fibromyalgia diagnosis, they really believe they have fibromyalgia, they're going to sit there and go, there's no cure to this. I'm just going to kill myself. And they do. They literally commit suicide. And they commit suicide for no good reason. We could have fixed them. The second reason it's bad is because people with fibromyalgia go, all your pain meds don't work, doctor. Fuck it. I'm going to go take heroin on the street. Or I'm going to go do kratom or marijuana, whatever. So they start doing all these dangerous drugs, or even better, alcohol, right? Alcohol's everywhere. They start drinking themselves into oblivion. The point I'm trying to make is simple. People that have back and neck pain, we can tell you exactly where it's coming from, and now we can fix all of it. And I don't believe in fascial pain. I don't believe in fibromyalgia. Why? Because every person that's ever told me they had fibromyalgia, I've cured their pain. How? By making the right diagnosis. So fibromyalgia, in my opinion, I've not seen a single case in 20 years. And all I treat is back and neck pain. So you go figure. Maybe they avoid me, maybe they don't, maybe there is no such thing. Maybe it's just doctors can't make the right diagnosis calling patients with fibromyalgia. Anyway, the point I'm trying to make is, if you have fibromyalgia as your diagnosis, do an MRI review with me. Let me try to figure out where your pain's coming from. I think I can figure it out, and more importantly, we can fix it and get rid of it.
Does facet pain feel the same as disc pain? Same question from Yin Yang He.
Does facet pain feel the same as disc pain? The answer is no, it does not. Just for those of you wondering the difference, the two major causes of back pain are the discs, which are these cushions between the bones being the hard yellow things. In the body, they're not yellow, they're white. But the disc here can be damaged, and that causes 85% of back pain, the disc. The facet joints, on the other hand, are these things in the back. You can see them moving, right? And facets move in flexion, extension. Facets move in lateral bending, and they move just really almost nothing in rotation, just a tiny bit. So really, the majority of movement of facets is extension, flexion, and lateral bending, okay? So people with facet pain, their pain is off to the side of the spine, and it's literally just about a finger breadth off of midline, whereas disc pain is usually deep and central. The disc pain can be to the side, to the right side or left side. The thing about facet pain that I find very helpful in making the diagnosis is palpation. If you push on someone's back to the side, just about 2 finger breadths off of midline. So 2 finger breadths off of midline. This being the midline between them, 2 finger breadths off. If you're pushing and palpating and that patient has tenderness, soreness, like, ah, it hurts when you're pushing, that's facet pain. Because you can never push on a disc. Disc pain cannot be palpated. So if the patient has central pain, it's deep, it's probably disc. If you palpate and there's no tenderness, it's probably disc. If you palpate and there's tenderness, it's probably facet. If you palpate, there's tenderness and it's off to the sides, it's probably facet. The other thing you could get is sacroiliac joint, which is kind of a giant facet joint between the sacrum and the iliac bone. And that could be, you know, just off the midline by the butt crack, and then you got the piriformis muscles in the middle of the butt cheek at the top.
The next question is from Tracy on Facebook.
Mm-hmm.
Curious if after performing a cervical DLDR, have you had any reports of patients that suffer from dysautonomia, such as POTS? See any improvements in the symptoms?
So the question is, after I do the cervical Deuk laser disc repair, have I had any patients that suffer with dysautonomia? No, I have not had those patients. I'm not sure why you would have, or somebody would have dysautonomia. Not after my surgery. That would be very unusual. I've never heard of it. We've done now 1,800 of these surgeries, and I've never seen dysautonomia. But there's lots of causes for those types of symptoms. I don't know that dysautonomia from surgery is the cause. There may be another cause.
The next question is from Jamie on YouTube. Can the back pain spread to the hips?
So Jamie is asking, can back pain spread to the hips? I'm not really sure how to answer the question. I mean, are you asking if when you have back pain, can it shoot out to the side? The answer is absolutely. Happens all the time. Very common. Are you asking me if you have back pain, can it cause you to have hip pain in your hip joint later on? The answer is yes, because you're walking bad. You could favor one side with a list, and that could wear your hip joint out. I'm not really sure exactly what the question is, but if you have lower back pain, whether it's disc pain or facet pain or SI pain, it can radiate into the hips for sure. I can figure out if you have a hip joint problem pretty quickly by examining your hip. And the way I do that is I'll have you sit down, I'll take your leg and your knee and I'll twist it. Okay, rotate your hip joint. And by rotating your hip joint, if that causes pain, especially with inward rotation, then that's a hip joint problem. But basically, I can usually figure out someone's problem is back or hip by physical exam.
Next question is from Eric on YouTube.
Well, first of all, we got a lot of questions, so thank you for asking questions. It's great to have so much interaction. Go ahead.
How often do thoracic spine discs degenerate and need a DLDR?
Great question, Eric. How often do thoracic spine discs have problems where they're causing pain, they degenerate, and they need a DLDR? Quite often. It's often thoracic disc problems are ignored by doctors because they don't know how to fix them. So they just say, take pills, go somewhere else, don't bother us, basically. The reality is we can fix thoracic disc problems. We looked at our thoracic Deuk laser disc repair outcomes. 1 year after surgery, 99.2% of the pain was gone permanently. So the Deuk laser disc repair does work for thoracic discs, even if they're degenerated. I would recommend you send us your MRI and let us do a MRI review. Do we ever get the name of the person who said they sent their MRI in?
Yes,
We know the name?
yes, we do get the name.
So we can find out from Sam what's going on?
Yes,
Did you already do that or not?
yes, I did.
And what happened?
Yeah, she followed up with him and he's scheduled now.
All right. Thank you.
Next question's from Tracy. I see that you are now performing DPRs on various joints such as hips, shoulders, knees, and perhaps elbows. Have you considered performing the DPR on big toe for patients suffering from hallux rigidus?
Yes, we would. Listen, thank you, Tracy. So Tracy's asking about the Deuk plasma rhizotomy. It's a new technology developed at Deuk Spine by me. It's basically going in and deadening the pain nerves to painful joints. We are not the first people in the world to come up with the idea of kill the pain nerve to a painful joint and you get rid of the joint pain. That's been around for a long time. Thank you. As a matter of fact, the first person to describe this, his name was Charcot, Dr. Charcot. He was a French physician, and what Dr. Charcot realized many years ago, like over 100 years ago, was that patients with diabetes, actually the diabetes disease killed the pain nerves to joints. And the patients, not just diabetes, but also, what is the disease? Leprosy. The parasite involved in leprosy causes nerves to the joints to basically stop functioning. And the patients would go from having painful joints, like painful knees, painful hips, and their pain would go away. And I'm not advocating people get leprosy, right? But Dr. Charcot noted this. You can look it up. I think it's CHARCOT, and described what's called the Charcot joint. And the Charcot joint is a denervated joint that no longer has pain. So doctors picked up on this and started to develop ways to denervate, take away the nerves, the pain nerves to the joint. That's what denervation means. And they developed this thing called a rhizotomy, where you try to kill a pain nerve to the joint. The problem is that the doctors that do this use what's called radiofrequency ablation, which basically, if you look at the tip of this paper clip, that's about how big the burn radius is. It's tiny, right? And they put it somewhere near the joint, and then they turn it on and burn. The problem is the nerve may not be where they're burning. It could be next to there. So what I did was I actually took a more powerful burning tool, and I actually brought it in, and I don't just burn with that more powerful tool, which creates a bigger burn radius, but I actually sweep it around where the nerves could be. So I create a field where we burn the nerve, okay? To me, I don't know why no one else ever thought of it, but it's pretty obvious to me that's the right way to do it. Anyway, we started doing it about 2 years ago, and now we have it submitted for a patent with the United States Trade and Patent Office, and also a few patents actually. But long story short, we're the first to do this. Are we doing it on toes? We haven't done one yet. but if you want to volunteer, we'll do it free of charge. I think it's a reasonable thing to try. And yes, we're looking at elbows. It's funny you say that. I have a patient who I offered to do her elbow. She has rheumatoid arthritis. She has horrible elbow pain. We did her hip, and I think her hip's doing a lot better now. She's out of state. But her elbow, yeah, I've been looking at doing the elbows, and to be honest with you, I've been doing a lot of research on innervation of the elbow joint, and it looks like we can do it. It looks like it would be safe to do. There is one nerve I have to be careful with. It's the ulnar nerve. It's extremely close to the bone where we would be burning. So I just have to be very careful with the ulnar nerve. But I think elbows may be in our future. The problem also with elbows is that they have literally innervation from 5 different nerves. So they have little branches going to the joint from up to 5 different nerves. Now, not every person has 5 nerves innervating their elbow joint, but you know, everybody's a little bit different. But it could be up to 5 nerves. The point is, we are actively investigating applying the DPR to other joints, and some joints are more risky than others, like for creating problems for the patient, like weakness, numbness, permanent. In other areas, we shouldn't be causing that. Other joints, like the toe, are pretty safe. So if you know somebody with bad joint pain, bring them to Deuk Spine. If it's a joint we haven't really established the treatment, we would be willing to use you as a guinea pig. I mean, let's be honest, that's what it is, in exchange for free services. So just contact us through our MRI review.
The next question is from Premier Media Group.
Premier Media Group, hi there.
Would traction help with removing the stuck tube?
Yeah, would traction help with the stuck tube? Thank you. I love the fact that you're here trying to help us solve problems. Yeah, traction is really hard to do. You'd have to grab the legs and have like 2 people pulling the legs and someone else grabbing the trunk and pulling the trunk. But even then, I don't think that would work. And just so you all understand what happened here, our tube in this case was at the L3-4, and it was so collapsed and twisted from the scoliosis that it was the disc, pretend this is the space, it was collapsed and it was like twisted and it was crushing the tube that was in here. And so we lost the tube and we lost the dilator. That's about $3,000 worth of equipment that's not disposable, by the way. But it's okay, we got it out and we move on. I can't think of any way that I could have circumvented that problem. We've been in that situation before. Sometimes having the patient deeper under anesthesia, especially if it's a patient with big muscles, the muscles are tightening down and clamping down on the bones, and they're pinching the tube. But this patient didn't have big muscles. He was pretty deconditioned. And it wasn't his muscles that were crushing the spine, crushing the tube. It was just his scoliosis and bone spurs and collapse of the disc that was crushing the tube. So I don't know that I could have done anything different. But trust me, it's at the back of my mind.
The next question is from Eric on YouTube.
Hello, Eric on YouTube. Thanks for joining us.
With such long surgeries, how is your back? And have you ever had any back procedures done?
Well, Eric, thank you for asking and being concerned. It means a lot. You know, the surgery is not that long, to be honest with you, and I appreciate your concern. The longest surgery I've done was 18 hours straight. It was a brain tumor, you know, what we call an acoustic neuroma. It was at the VA hospital in Gainesville on a vet who had a tumor. That was painful, 18 hours. I had to go to the bathroom a few times, had to grab some Wendy's. But that said, these surgeries that take 2 hours are pretty good. Honestly, I'll be honest with you, they're a dream. I mean, compared to the surgeries I've been in over my lifetime, most of our surgeries as neurosurgeons, they're 4, 5, 6, 7 hours of operating. So I have Absolutely nothing to complain about. I am honestly, truly blessed to be able to do these surgeries this short. I almost feel like I'm cheating my, my profession by having such short surgeries. I almost feel guilty about it, but then again, I am focused on the fact that we're helping people's lives and getting them out of pain, and that's what matters the most. So I have nothing to complain about the length of the surgery. I did sweat a lot. If I was going to complain about one thing, it would be the temperature in the operating room. It was a little warm, and I'm still trying to figure out why that is. I have that question out to Luis. He's going to do some investigating. But I did feel the cool air kicking in a little later, so I don't know what happened. Maybe somebody raised the temperature. Anyway, thank you for your concern. And the surgeries aren't too long.
That's it for the session.
All right, well, thank you all. We do have another case coming up. It's another lumbar Deuk laser disc repair. Hopefully, we won't be destroying our equipment on the next surgery. This next patient he's from Wisconsin. And I asked him, where's your cheese hat? Why didn't you wear your cheese head? And he said he left it back in Wisconsin. So he will be having the Deuk laser disc repair bilateral L3-4. And I think it's a left L4-5. So we're fixing 3 spots. 2 at L3-4, 1 at L4-5 with the Deuk laser disc repair. I don't think he has the Deuk plasma rhizotomy, so I don't think he has any facet pain. It's just disc. A very nice man, and we'll be bringing him back shortly. So thanks for joining us. Check back in about 30 or 40 minutes.